Hello, my name's Simon Kennon. I'm editor of Interventional Cardiology Review, and I'm here with Olivier Muller, who is an interventional cardiologist from Lausanne in Switzerland. Olivier, thank you very much for coming, and we're going to be talking about left atrial appendage occlusion. So I don't do this procedure, and looking at it from the outside, I can understand the idea that most of the clot that forms in atrial fibrillation forms in the left atrial appendage, so occluding it is in principle, a good idea. The problem from my viewpoint is there are complications associated with the procedure, and that automatically puts it at a disadvantage compared to pharmacological anticoagulation. So you could then say, well, let's use it for people who can't have anticoagulation, but of course, as I understand it, you need to anticoagulate people for a period of time before and after having the device put in. So if we can just go through these issues so everyone else can get a clearer idea of the place of left atrial appendage occlusion. What do you think, perhaps in your own experience or from registry data, what is the complication rate of left atrial appendage occlusion in experienced hands?
So, indeed, I would like to see this procedure in another way. You are looking at the complication rate. Indeed, we shouldn't have complication when you do a procedure, or at least you should have like less than 1%. This is the ideal view, but you have to see that these patients are very complicated and they are bleeding, they have stroke. So this is not someone that you can have warfarin with a low bleeding risk, and then you do a procedure and you have a complication, which is the worst. You have a high bleeding risk. This is the patient that you are having at least in the registry, also at least in the randomized control trial, you have only two, the PROTECT AF and the previous trial, where the bleeding risk is more than 2.5, something like that. So it's not a very high bleeding risk, but indeed it's a bleeding risk which is higher than the simple patient, I would say. So this is the view that I see. It's not that you have a patient and you make a complication. You have a high-risk patient and you have a complication. So to come back to your question, is I would say that the complication rate in expert hands is around 2.5 to 3% device-related, procedure device-related complication. This is what we see in the last registry, the evolution registry, but also in the amulet registry performed by Dr. Tsikas on more than 1,000 patients. So this is more or less what we see. Indeed, it's too much.
And when you say 2 to 3%, that is what complications?
So this is indeed death, tamponade, systemic embolization, stroke.
Okay.
This is too much indeed. But what we can see is that we started with the PROTECT AF trial. We had more than 8% device-related complication, and we end up to 2.8 with the evolution registry. So there's a big improvement in terms of complication rate, but indeed it's too much currently.
Sure. So we're talking about expert hands. How many cases do you need to do to become an expert?
As much as you can.
Yeah.
But you can see in the evolution study, I think, or the amulet registry, more or less the majority of centers are performing between 10 and 25 per year, which is actually a rate that you can find everywhere in the world. Some centers are performing more than 100. To come back to your question, do you have more complication if you are performing between 10 and 25? The answer, based on the registry evolution, is no. Mm-hmm. And this is based actually on the education that the company are performing for the first implant. So okay. They are doing a very well and good job, to my point of view. They're giving you education, proctoring, and they bring you to a level that make the complication rate quite low, to my point of view.
Okay. So who should be doing these procedures? Interventional cardiologists, EP, both?
I would say that the EP physician have the patients. But we, interventional cardiology, have the know how to deploy an implant, and I think both physicians should be in the procedure, to my point of view.
Okay, excellent. What is the antithrombotic regimen required around before and after the procedure? Is it antiplatelet agents? Is it warfarin?
This is the big issue of the LLA closure, indeed. So we have no randomized control trial saying that you need a specific antithrombotic therapy afterwards. What we have is an expert consensus where you give more or less 3 months of dual antiplatelet therapy and then lifelong aspirin. This is more or less what the expert consensus is telling. But we have the last registry from CICAS where you have a patient with only aspirin after the procedure. We don't observe any adverse event in this subpopulation. And we have also, it's not published yet, it's a communication from Dr. CICAS, but we have 70 patients that have the device and had no medication afterwards.
Right.
To my best knowledge from my discussion with Dr. Tsikas, there's no event in this subpopulation. So it's a very small group, but we need data to assess that kind of... Indeed, it's a very big issue because these patients are at very high risk of bleeding, and you give medication like aspirin and clopidogrel. So it's a big issue, and we need to have further studies.
That's quite encouraging, though, 70 patients. The data coming through. Do you know when that data is coming through?
No, I don't know.
Okay. So could you summarize for us who are the sort of patients that we should be referring for left atrial appendage occlusion?
In 2016, to my point of view, you have to have a high-risk bleeding patients. You have to have either a low-risk bleeding patient but had a cerebral hemorrhage, so you are very afraid to giving heparin again, warfarin again. So these are the two populations: high-risk bleeding or had an event before and you are afraid to give warfarin because you cannot identify this patient having a bleeding risk, but he had the bleeding. So these are the two populations.
And is that going to change?
Hopefully for us, but we need further data, to my point of view. We have to assess. I don't know if someone will have the courage to perform a study, a randomized control trial with the high bleeding risk patient. We don't know yet. I think that several PI are starting studies, but it's a little bit early to tell you something now.
Do you ever think we'll get to a position where it could be a routine treatment for atrial fibrillation?
It's going to be very hard to beat the NOAC, to my point of view, in the low-risk bleeding population. So I would say this will be a niche for high bleeding risk patients.
Okay. Olivier, thank you very much.
Thank you very much.